Thank you. From a very personal note of gratitude to all our friends that you all have given us an opportunity to be with you for this wonderful, very well organized meeting. It will be a big favor if you can shut the door for a while, because I don't think it's adding a lot to the oxygen saturation that is needed. Friends, cardiac surgery is in some sense a wide topic. And in some other senses, cardiac surgery, please remember, we are the youngest kid on the block. If you compare cardiac surgery with any other field of surgery, whether it is gynecological, which was somewhere, already implemented in the times of Julius Caesar, from gastroenterological surgery, which already reached its zenith in the times of Billroth in Vienna, we are the newest and the oldest kid on the block. You did not have the first meaningful cardiac surgery till well into the 1960s. So it is not only rapid, it used to be and perhaps still is in one of the commonest surgeries presented worldwide, done worldwide. There was a time in the United States when you had more bypasses than appendectomies being done. The profile has changed, but today what we will discuss with you is an update in what is happening to something which is very familiar to all of you, which is regarding coronary bypass. So we focus on coronary bypass today. You see, cardiac surgery, or for that matter, anything to do with cardiovascular medicine, starts with an admission. And that admission is that the mere terminology, all the time we talk about arteries, 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 but we have to do so from a position of guilt. We have to realize that the mere word arteries is a misnomer. It is a great mistake, historical mistake, because whoever termed the word arteries, it does not actually mean that blood vessels that take blood. The word arteries actually means tubes that convey air, oxygen. And that is why arteries were called arteries air and turon, a mistake that was made somewhere in the 6th, 7th century BC, and we are still living on with the same mistake. There are some people, to whom this whole evolving area of surgery, we all did, or we are supposed to take the Hippocratic Oath when we qualify in medicine. And Hippocrates, in his 65 pages of Hippocrates' treatise, as they called it, said one thing repeatedly, that you will never operate on the heart. The Greeks were extremely scared of operating or cutting open anything that contained blood. So we, the people who today practice cardiac surgery, do so going against the edicts of Hippocrates, etc. A succession of people, many, many more, starting from 1917, the last surgeon to have been given the Nobel Prize, Alexis Carrel, is probably a founding father of vascular surgery. Born of very poor family, very poor parents, Alexis Carrel's mother used to stitch torn clothes for a living. And Alexis Carrel saw his mother stitching torn clothes. And that stitching technique, that technique of continuous suturing, he applied from his mother's torn clothes to the blood vessels. And that's how vascular surgery, because you had no continuous stitching before that. That is how the fundamentals of cardiac surgery established. History is very funny. We got to know a little bit here and there. People got to know that if the arteries get blocked, you get lack of blood supply. If it happens in the heart, you get angina. But we had no way of detecting. How on earth can you go and detect a blockage inside the heart? In other words, to do an angiogram. And the coronary angiogram again happened by mistake, because this gentleman, Mason Soanes in Cleveland Clinic used to smoke all the time. Every 20 minutes, 15 minutes, he used to have a cigarette. So he was doing a different vascular catheterization. He went out for a cigarette. He left the catheter to his trainee, and the trainee by mistake floated the catheter into the right coronary artery, and by an app, and the patient had ventricular fibrillation, had a cardiac arrest, had to be massaged on the table, somehow survived, and that is for the first time. It is because Mason Sohn was an incorrigible smoker that we realized that coronary angiography was actually possible. And then, as people were struggling, the first coronary angiography was done in 1958. For almost 10 years after that, now we know that, arteries get blocked, people get chest pain, you get myocardial infarction, but we didn't know what to do about it. So as everybody was struggling and trying to find out how on earth do you go and correct this condition, this surgical trainee, he had not got his degrees yet. You have famous Argentinian footballers. René Favaloro was a young Argentinian trainee who was training in Cleveland Clinic. He saw all these people trying out different things, and this fellow, humble trainee, suggested the technique of saphenous vein graft to the coronary arteries, and that really led to an explosion in the field of surgery. The first bypass was done in 1967. 1967, for those of you who care about the history of medicine, is a great year in the history of surgery. In May 1967, you have the first coronary bypass. In December 1967, you have the first heart transplant. And somewhere in the middle, in October 1967, you have the first liver transplant, the first successful liver transplant happening at Johns Hopkins. So 1967 was a very busy year for surgeons. Thereafter, let us remember a few surgical principles. The entire difference between interventional procedures like an angioplasty and a coronary bypass is basically one. In angioplasty, which is good and effective, they are actually dealing with the diseased portion of the arteries. And in coronary bypass, most of the time, we are dealing with the healthy part of the arteries. We do not intervene directly where all the grunge, the atherosclerosis, and the plaques are. So some of the difference in long-term outcome that we will see is possibly due to this one principle, that we are not getting on headlong in the severely diseased part of the arteries itself. When you go through the annals of surgery and try to find out one particular publication which made a tremendous difference to the outcomes and the way surgery is practiced later on, it is this particular paper which comes out from Dr. Floyd Loop, again at the Cleveland Clinic in 1986. So for coronary surgery, which had just come onto its own in the early 1970s, within the first 16 years, they come out with the surgery of putting the left internal mammary graft on the left anterior descending. And why was it so important? Because this was one surgery that did not talk about graft patency. It did not talk about the trivialities of surgical technique. It spoke about one thing. In a matter of a few years, there was a dramatic difference in the 10-year survival of patients. So this is perhaps an epical paper in medicine where this is one technique, and you can think of anything to do with medicine which makes a substantial difference to the 10-year survival of human beings. We went on, left internal mammary, all of you know, was a very good thing. Left internal mammary with maybe a combination of vein grafts was considered to be the standard surgery. And then our colleagues started thinking about, what about if we extend the concept? What about we start using the left internal mammary along with the right internal mammary, along with the radial artery? Will it further improve results? Will it further improve outcome? Was a $1 million question. And there were many, mostly retrospective studies like this, which did point out that if you extended the usage of arterial grafts, your outcome further improved. Now, there are two things that we study for ourselves. Our central milestone, our central focus, number one, is you are doing a vascular correction. How well are the grafts patent? So graft patency, the patency of the graft, you've joined A to B, they've got to flow, they've got to work, they've got to function. So graft patency is paramount. And thereafter, we have operated on a 50-year-old. So sending the patient home at 7 days is not the end point. The end point is following up the patient for the next 10, 15, 20 years. So these are the two parameters that crop up repeatedly in our work. So when we look at the graft patency of the extended arterial grafts, they were superior to that of the vein grafts. Even the vein graft patency improved. Why did the vein graft patency improve? Not because we were stitching better. The vein graft patency improved because of the adjuvant medical treatment. With the advent of statins, with the advent of dual antiplatelet therapy, vein graft patency that is seen in this era compared to the last era is largely different. So when you talk about, there is a whole lot of clamor, there is a whole lot of skirmish, people trying to say, this is for PCI, this is for CABG, this is this, this is that. Do not complicate things. Keep one central idea in mind, and that is, for limited disease, for early disease, for non-diabetics, heart has 3 coronary arteries. For things like single vessel disease, double vessel disease, limited coronary disease, maybe more so in the non-diabetic population, percutaneous intervention, in simple terms, angioplasty, will be the treatment of choice. And as of today, coronary surgery is reserved for the heavy lifting. We are the heavy lifters. We are heavy lifting in 3 vessel disease, in calcified coronaries, in 100% occlusions. So there is a demarcation of territories, and that is well supported by the guidelines. I did not want to bother you. There are very well laid out guidelines that what treatment is effective in what condition. So world over, you see that depending upon the society, depending upon the country, their biases, there is a ratio. In India currently, there are about 2.5 to 250,000 coronary surgeries done every year. And in India today, we perform about 700,000 angioplasties. So the ratio that is prevailing in India today is somewhere at 3:1. So if you consider the total number of people who undergo bypass plus angioplasty, it's almost like the population of a tier 1, tier 2 city. So every year we are adding a city to India when you do coronary procedures to about 100,000 to about a million people. There are certain, I do not want to overburden you, there are always graphs, survival, patencies, etc. But there was a period of time when there was tremendous debate that how does angioplasty do, how does bypass do. So what we just said, the summary, that for the less complex disease, angioplasty fares equally well. But when we consider complicated disease, diabetics, these are the kind of studies. There was a trial called the Syntax trial, which is the kind of the North Star of academic medicine in cardiology and cardiac surgery today. And basically what it showed, that the longer you followed up the patient for complicated coronary disease in diabetics, results of surgery were better. Not only were results of surgery better, but what is important is, today you're operating on a 50-year-old, a 55-year-old. You are not looking at a 1-year survival. You are not looking at a 2-year survival. You are looking at a long-term outcome. Even in India, your median life expectancy today is 71, 72 years. So it is not enough to operate on a 50-year-old and send them home and say that consider yourself lucky if you've survived for 3 years. That is poor medicine. So once again, in complex coronary disease, the longer you follow up the patient, the difference between bypass and angioplasty in complicated diseases, it becomes more and more pronounced. In surgery, we are always complaining with our cardiology friends. We are very good friends with them. We don't quarrel too much. Almost, there is some message coming over here. What is this? Can I have somebody over here, please, quickly? Some back-end person. What is this coming out? Some one drive, two drive. What is this? Can you just switch it off? Take it. So I'll just give you some of the nasty stuff that we have to deal with. How big is a coronary artery? A coronary artery at its biggest is about 2 millimeters in diameter. I don't have much left on my head. For those of you whose scalp is a little bit generously covered than mine, it is about 5 of your hairs put together. So that is the arteries you are stitching. And when some of these arteries become completely blocked and choked up with calcific atherosclerotic plaques, you see, we are called upon to tease out these plaques from the coronary arteries. This is the kind of stuff that comes out. So many of you may have seen peripheral endarterectomies. So coronary endarterectomies are still quite a prevalent procedures. Very often we do triple vessel disease, of which 2 vessels are completely knocked out by solid atherosclerotic plaques. So complex plaque division. Plaques are like wood. You can't really stitch an artery on a vein to a stone. So you have to clear the coronaries whenever required. And we do so. Nowadays, it is like repairing an engine when the heart is working. So this is a beating heart surgery where so this is a complete left anterior descending artery which has been cut open from the base to the apex. The whole artery is laid open. The entire plaque is taken out, and only then can we restore the circulation. There are certain difficult areas, very difficult areas. The starting point of the cardiac circulation, the left main artery, 15% of all coronary disease happens in the left main artery, and the left main artery lesions have to be detected early. Because other than that, if you've had a myocardial infarction from a left main artery, God save you, because in matter of minutes, 3/4 of your myocardium will be knocked out. So in left main coronary arteries, also looking at their survival, bypass remains a better option. And where the difference is extremely remarkable, that is in low ejection fraction. About 80% of the people come for intervention by the time they have already had 1 or 2 infarcts. So by the time, if you've had 2 infarcts, you will be very lucky if your ejection fraction is anywhere between 35 to 40% as compared to a normal of around 60-65%. So in low ejection fraction, say in a diabetic with multiple coronary artery disease, this is one of the difficult, it is challenging, but it is one of the areas where the long-term results of bypass are remarkable. And similarly in diabetics, if you follow up diabetics, in India, you need a few things to prove your identity, either an Indian passport, an Aadhaar card, or your blood sugar levels. If you are a diabetic, nobody questions your Indian identity today. And given this prevalence of diabetes, this is something which is important in our area of work, because the longer you follow a diabetic, the more intent you have to be on the long-term outcome. Now, we have to be aware of the fact, where are some of the weaknesses, where are some of the pitfalls. We are in the business of making the blood supply normal, or in other words, complete revascularization. So if you get into an operation or you get into an angioplasty where somebody has a triple vessel disease, and you go out of it correcting 1 artery or 2 arteries, and you think somehow the person has gone out of the theater, so all is well, that is extremely wrong. The medium-term to long-term outcomes of incomplete revascularization are poor, no matter who tells you what. So whether we are doing it with a bypass or an angioplasty, complete revascularization is absolute priority. There are some other additional problems which can only be corrected with surgical intervention. Post-infarct, the mitral valve will weaken, the ventricle will dilate, and in that setting, along with coronary artery disease, we are going to see ischemic mitral regurgitation. If the ischemic mitral regurgitation is severe, you cannot just put 2 grafts or 3 grafts and send the patient home, because the guy will go home and start and continue to be breathless. So in that case, if the mitral regurgitation is severe, then it is very important to repair the mitral regurgitation and then do the bypasses as well. Now, as time has gone on, we, the surgeons in India, had our own share of innovation. And one of India's gift to bypass surgery over the last 20 years has been the concept of beating heart or off-pump surgery. Till about 1990s, routinely every surgery used to be done on stopped heart, heart-lung machine, and the whole paraphernalia. Around 70% of coronary bypass today is done on off-pump beating heart. What is the advantage? Less physiological stress for the patient, earlier recovery, less transfusion, less ventilation. So it has its own advantages. There was a lot of controversy that whether when you off-pump is like a bit of an acrobatic act, that you are trying to stitch these little coronaries with the heart beating in front of you all the time, or is the grafting outcome, is the grafting result as better? So we in India, 5 surgeons got together and we did what is considered to be the first randomized controlled trial of coronary surgery from India. For the first time ever, we studied more than 500 patients with postoperative angiograms in off-pump surgery, and to cut a long story short, the outcomes were comparable. So even with off-pump work, you compare across the 3 territories, the outcome was good. We have recently completed our second RCT, which is how does a diabetic do with a second arterial graft. We have just collated the data. The abstract will be presented in the American meeting this year. So it is difficult to do serious academic work from India, but we are at it, we are persistent. So the PREDICT trial will be the second academic work from India going on. At the end of it all, you must have heard, you are familiar with the term of minimally invasive cardiac surgery. Now, why was minimally invasive important? Because cardiologists in a friendly kind of way was always poking us for our sternotomy approach. You had a big cut down the middle. Years ago, a sternotomy used to be a status symbol. You went to a party, you told somebody, I've had a bypass, your social status increased. But then the cardiologist used to say, we are doing it with a small hole in the wrist. So the cardiac surgeons got together and devised certain very ingenious techniques. Today, there are minimally invasive surgeries done with a smaller left side of the chest, a small anterior thoracotomy, as opposed to a full-blown mid-sternotomy. But mind you, as I tell my patient, measure your life in years, not in inches. So when you calculate your age is still measured in years and not inches. So if it is a complex disease involving right, left, both aspects, it is still today a sternotomy. Supposing you have a double vessel disease both on the left side, it's basically a concept of geography, then minimally invasive surgery is quite effective. Minimally invasive surgery, the approach is very different. I won't bother you with the surgical details. As opposed to the middle of the chest, you have these smart little retractors, and with these little retractors, we harvest the mammary, we do the anastomosis all at the same time. But it is effective. And once again, it is not enough to sell you a gimmick. We are doing a small cut, doing bypasses. Once again, you have to go back, do angiographies, study the grafts and prove that the grafts are working. But remember, minimally invasive surgery is done in selective cases. It is not an all-comers operation like your conventional bypass, but in those selective cases, graft performance is good. The newest innovation in the block, which we have put our hat on the ring, we've done about 15 of those so far, is this new concept of robotic surgery. We have a Da Vinci robot with us. The Da Vinci robot, there are 15,000 Da Vinci robots all over the world, and robotic surgery is very popular mostly in pelvis, in gynecology. Those are the areas where robotic surgery dominate. But we are getting into the act right now. What do? We use the robot mainly. To harvest the mammaries. This is the robotic ports going in like any other robotic work. So once the ports have gone in, we are using the ports to harvest the mammary artery, because in that case you don't even need that, the cut in the chest can be even smaller. So we are harvesting the mammaries through the port, and after we have harvested, the anastomosis is still done hand-sewn. There is a lot of development going on for robotic connectors. Connectors, which is you will put it's like two staples. You'll put them through the two arteries, fire the staple, the arteries will connect. Mind you, looks good on the drawing board, still not widely available. There are anastomotic connectors, but for all practical purposes, for most robotic work, the anastomosis is still hand-sewn. Robotic graft patency, we have to be careful. In a very selected cohort of patients is pretty good. Now, the basic concept that I want to leave you with today, that it is not a matter of sibling rivalry between an angioplasty and a CABG, but coronary bypass has held its ground. And why has it held its ground? Because it is capable of tackling the severe problems, the diabetic, the calcified disease associated with valvular lesions, poor ejection fraction, and at the end of it all, it is giving something that all of us want, and that is better survival. And one example is one of the recent publications from the Journal of Annals of Thoracic Surgery. Now people are coming up with 40-year data. Next month, we are going to have 50-year data on the patency of arterial grafts. There are not many surgeries on the face of the planet today who are publishing 40-year and 50-year data for an operation that was only invented in 1967. So it's still the long-term outcome, the survival, which remains the strength of coronary bypass. In Eastern India, coronary bypass or cardiac surgery has grown in great leaps. Today, the centers around India does about 250,000. We in Eastern India today are little short of 30,000 procedures per year. And we in Manipal hospitals, I look after the Manipal cluster in Dhakuria and EM bypass. We do about 2,000 a year, and perhaps we are the largest cardiac unit in Eastern India right now. I don't think there are any other units whose either volume or spectrum of cases. We do everything, starting from a 2-day-old kid to a heart transplant. So from neonatal to heart transplant, we have our colleagues who are performing the entire range of cardiac work. How much do we know? I think in Eastern India, we are only doing half of what we are supposed to do right now. We have our concerns. We'll discuss this later. There is a lot of inappropriate referrals for PCI. Once again, this is not selfishness. But when we make inappropriate referrals for angioplasty, remember at the end of the day, you have perhaps compromised on the patient's survival, not in terms of 7 days, but in terms of the next 10, 15 years to come. And there is a calculation which says that if you select your cases well, and 10% more deserving patients come to the bypass category, you would have saved 3,600 lives per year and about 1,000 crores in revenue. That is what will be the impact. Both as surgeons, as cardiologists, as non-interventional cardiologists, be aware of the fact that in India we are still severely underperforming. If you compare ourselves with the benchmarks, we are a kind of mid-low income country right now. Compared to our current benchmarks, it looks very good. We are doing 250,000 coronary bypasses, about 300,000 heart surgeries per year. But we have to remember that is gross underperformance. I have just written a paper that will be published in the next couple of months just to show that India currently is only doing half of what it's supposed to do. All these things about, Viksit Bharat and everything is emotional propaganda is fine. But if you put your emotion to numbers, you will realize where you are in reality. And as we become a kind of middle income country by next year, our performance gap will be even more. So I think we are only at 50% of our capacity now. We have to diagnose more, we have to detect more, otherwise we are not doing justice to this disease spectrum. And let us remember that with an insured population, I am not talking about people who cannot afford, with an insured population which is 3 times larger than the population of United States, we are not even performing half their numbers. This is something that doctors in India should be severely concerned about. The insured population of India is 3 times the population of United States. So our goal should be that we detect more, we allocate therapy smarter, we treat better, we save more lives, we conserve resources, and at the end of the day, we have to do our specialty some respect. Thank you ever so much. If you have any questions, I'll be happy to answer.